good afternoon and good morning to everyone, depending on where you're joining today's session from. A very heartfelt and warm welcome to you. Thank you for joining. My name's Blake. I'm a Senior Implementation Manager at BAO Systems based out of Cambridge. And just to confirm for everyone that you have come to the right place, today's session, or this particular session, is now on DHIS2 and COVID-19 vaccine delivery tools. I'd encourage everyone during the session to feel free to submit questions all the way throughout. If Rebecca and Mike spot questions that they're able to answer in the flow of the presentation, they will, and there'll obviously be time at the end as well for for Rebecca and Mike to answer your questions. So there's about 45 minutes for today's session, roughly 30 for the presentation, and 15 minutes for Q&A. So plenty of time to dig into what you want to find out more about from them. So don't hold off. Please ask questions in the Q&A box on the right of your screen throughout. Today's session is going to provide an overview of the available DHIS2 options and tools for supporting COVID-19 vaccination planning, delivery, and monitoring. And our speakers for the session are Mike Frost and Rebecca Potter. Mike's a senior advisor with the Health Information Systems program at the University of Oslo and the project manager for DHIS2 Tracker, or product manager, I should say. And Rebecca is the UAO technical lead for global health content. And with that, Rebecca and Mike, I'll hand over to you.
Okay, thank you so much, Blake, for the intro. So I'll go ahead and switch to view here. I will just update you a bit on our work from the University of Oslo. As many of you probably know, the university, it supports DHIS2 as a free and open source software platform. And we're going to share a bit about how this has been used throughout the COVID-19 pandemic and now with response. So around this time last year, it was actually more March last year, we had released a set of DHIS2 metadata packages and tools to facilitate a number of countries who were looking for a solution that they could build on top of their existing DHIS2 systems that were in the country to be able to wrap the COVID-19 case-based surveillance, in addition to collecting other types of data, being able to facilitate their situation reports and other things. So at that time, we had actually already been able to learn a bit from a couple countries who had pioneered, such as Sri Lanka, actually started by adapting their DHIS2 system to become entry screening using the DHIS2 tracker model. And from there, it really exploded through about 39 countries ended up using DHIS2 for some form of their COVID. So coming towards the end of last year, when the vaccines started to get different types of approvals, we also started to shift our focus for how can we support the community to use DHIS2 to expand their existing national immunization platforms to also respond to the COVID-19 vaccination challenge. So the WHO, they developed the National Deployment and Vaccination Plan guidance to support countries to be able to develop a plan for really an unprecedented campaign. And parts of this plan really focused around being able to measure equitable coverage, to monitor how the national policies were prioritized groups, some things around how to do personal vaccination records and certificates, as well as pharmacovigilance and safety monitoring, monitoring individuals for the full course and ensuring if there's any adverse events, they get reported. And then, of course, bringing all of this data together with the strengthened supply chain information system. So understanding your vaccine utilization and wastage rates and traceability, as well as the actual vaccines administered. So the WHO provided the framework for what we started to develop, DHIS2. So the DHIS2 Toolkit for COVID-19 vaccination. We actually have been partnering with the WHO and with Gavi since 2016 to develop a series of modules in DHIS2 that would be aligned to global guidance around EPI programs to strengthen the routine immunization platforms within countries. So that toolkit started with a core EPI module. So it was the aggregate reporting and analysis and dashboards, multi-level dashboards around vaccine utilization, coverage, dropout rates, and things like that. So we had a very strong model, and then we started to expand upon this and build out some modifications to be able to accommodate the specificity of the COVID-19 vaccines. But we'll share a little more later about what that looks like. We also do some support for facility and last mile logistics, so really at that vaccination site level, using the tracker-based module to develop an electronic immunization e-registry that can be used in hand with these sort of core routine EPI module reporting. Some innovations around how do we align this immunization registry to make sure that we're capturing the core data points that would be needed for electronic health certificates, and how would we link with certificate generation systems. Consider multiple distribution strategies. So there's sort of routine immunization, and then also you might have heard of measles or rubella campaigns. So where a country might take like a 2-month block of time and attempt to administer vaccine to every person within a geographical area and within a group. And then what we're seeing with COVID-19 is a little somewhere in the middle between this sort of campaign style and this routine style. And lastly, but very important, really working through what is this adverse events reporting, and how can we facilitate the quality of that reporting and the investigation to be able to feed that data into global pharmacovigilance and safety databases. So our approach to supporting countries has been to build upon the established partnerships and approaches that. And so part of this is really leveraging the WHO DHIS2 Health Data Toolkit that we partner on. But also working through regional support networks. There are 13 HISP groups around the world in Africa, Latin America, and Asia who sit very closely to the countries that they support and have strong long-term relationships with the ministries of health. We also really focus on strengthening existing systems and tools and capacities. So coming in, 45 countries already use DHIS2 for their national immunization program information system. So we knew if they wanted to be able to develop something that would be sustainable for the long term, and also to help them strengthen the system that they had for routine immunization, that if we work through the DHIS2 modules and strengthen the use of that, we think that this will have some long-term impacts on the country. And lastly, our philosophy really is around leveraging expertise at the local level. So within countries at the district level, and building this kind of enabling framework to share best practices and innovations globally. So as of yesterday, when we pulled this map, we do have 24 countries who have informed us that they have operationalized one of the DHIS2 modules for COVID-19 vaccine delivery. And for us, that means operational means the users have been trained, it's set up in a production instance, and there's data now being entered into the system. We have another 8 or so that are in development, so we do expect that this number will continue to grow in the coming weeks and potentially months. But I did want little bit of, how are we kind of able to scale this approach? And so much of this comes back to the collaboration with some of our really core health system strengthening partners like Gavi and Global Fund, who have partnered with WHO and the University of Oslo for many years to really develop these global standards and think carefully about how can we design national health information systems to support the analysis framework that's being set by the WHO, but also in a way that we can really explore how are these modules working? How are the dashboards designed to support district use? How are we developing individual level tracker systems that also accommodate the workflows that we see at a facility level or at the very lowest level where service delivery is happening, community or in the facility? So we believe that this approach that has been built and expanded since 2017 also gave us a starting point to be able to disseminate these solutions through countries. So this is where I will switch a couple demos about what parts of this toolkit, what do they look like. this instance here, it contains actually all of the COVID-19 surveillance modules, and then we also added in, this is just a demo instance, but we also added in the vaccine delivery. And through a partnership memorandum of understanding with WOW PDR, they graciously allowed us to use their data hierarchy, but this is not their real data. This is just dummy data that we've created for demo purposes. So in terms of surveillance, the many countries that scaled up for surveillance, they have their epi curves here. They have their dashboards that are giving them the key metrics around suspected cases, confirmed, the total deaths, all of these key numbers that the epidemiologists are tracking on a day-by-day basis, and also using to understand where outbreaks are happening at localized levels. And then if I switch over, so now we have the COVID vaccine delivery dashboard as well. So this dashboard is actually based on the aggregate module. So there's a core module that we developed, and I will show you what this looks like in the, actually in the EPI program. So I said that we had been working with WHO and immunization partners for many years, and part of that work was to develop a set of standardized dashboards for immunization program monitoring. And the key metrics that end up in here are generally coverage by geography, by different types of groups, some tracking of tracer vaccines that are delivered, just to understand uptake, as well as key metrics around dropout rates, and closed vial wastage, open vial wastage. So looking at those key supply chain indicators at the lowest level of service delivery, and bringing this all together also with the cold chain. So we felt with this, this kind of baseline, we really are covering the main components that countries need to be monitoring for the operational effectiveness of their COVID-19 vaccine rollouts, but also to monitor things like coverage and quality. So here we essentially took very similar metadata design or DHIS2 design, but we updated it for the requirements of COVID-19 vaccines. So for example, at the moment, there are many different types of vaccines that are coming into countries. So countries, they don't just want to measure, okay, COVID vaccines, they actually want, of course, to be able to see what do these different numbers look like between Pfizer or AstraZeneca. So that was kind of a level that was introduced. We also have an interesting challenge in that the target populations look quite different. So of course, the aim eventually is to be able to vaccinate the entire population, but according to a phased plan where you're prioritizing those who are most at risk, like your health workers or your older populations. To incorporate some of the population numbers, many of them, there's some population data that sits in the health information system already. And then in some cases, for the specific target groups for COVID-19 vaccines, this kind of data needed to be estimated and modeled and generated as performance as target denominators for the first time. So this aggregate module, first I'll show you what the data entry looks like. So I've gone into Lao PDR and I went down to the Vientiane province, and I'm going to start with the provincial hospital here. So we've designed a daily vaccination report. Normally, EPI reporting routine immunization is generally monthly, but there really is a strong desire to be able to get this data faster and to facilitate some real-time monitoring through daily data sets. So we have the vaccines administered by different types of target groups. Of course, as well as some calculations. If I have all of these different types of groups, then what do I get at the end? And a really, really basic reporting, just a summary reporting of these sort of adverse events. So very straightforward. And then, of course, I have the stock report. And so this is not trying to replace an electronic LMIS, but at the vaccine site delivery, at least being able to say, you know, this is the number of doses I have on hand, but also these other stock items like cold boxes or vaccination cards or diluent if it's needed, just to be able to get a sense of what's happening. And all of this ends up translating into quite a nice triangulated dashboard. So we are able to get some mapping around the percentage of people who are being given their first dose, some quality, equity, I'm sorry, not quality, but equity metrics around proportion of male versus female. Are we truly targeting the right groups? What is the uptake by different types of vaccines? And then digging down into thinking about, okay, well, what is the stock on hand? And can I drill down to this facility and see if they have anything left over? Because of course, we want a lot of visibility into making sure that the stocks, that as soon as they are received, that they can be used in efficient time, which is a bit unique to the nature of this current campaign. And so this is the starting point that we promote for many countries. We also believe that in many places it does seem feasible that they can be doing daily or perhaps weekly reporting. So there are ways for them to get a complete data set and do this monitoring much faster. But this is kind of the core module and where we start. And where we go from there is really where I will hand over to my colleague, Mike, who will dig into some of the different modules that we've used the DHIS2 tracker, which tends to have a bit more of a complex configuration. So with that, I am happy to hand over to you, Mike.
Great, thanks a lot. I'm going to go ahead and start sharing my screen. Okay, great, you can see now. So yes, thanks, Rebecca. You went over a lot of the content related to the reporting, the monitoring, the surveillance. Some additional areas where DHIS2 is being used extensively for COVID vaccine are related to the individual level data. So within DHIS2, that's the tracker application that allows you to do longitudinal individual data collection. And we've created several modules working with our counterparts at the WHO, with UNICEF, with Gavi, and others. The first one that I just wanted to show here is the vaccine registry. So this would be meant to be used at the point of care, either directly during the visit with the patient receiving the vaccine or as kind of secondary data entry, but from the individual case file. If you're familiar with Tracker, then you would already recognize that there are the standard tools that are available in order to register an individual. The system, for example, can be set up to generate a unique ID for this given interaction. It, of course, can be linked also to a national ID database, or it can be used to enter in any other kind of identification that would be valuable in the country that you're supporting. It also is configured to capture the kind of different demographic identification that could be useful in identifying the person, particularly because with the COVID vaccines, the majority of them are 2 doses. You would want to make sure that you can find that individual record this next time when the patient comes in. So you can register them here. The system would be looking for any duplicates. Even if you haven't told it to do a search, in the background it will be conducting one. Or you could be simply conducting a search of an existing patient that you already know is registered. The search can work off of either a couple of the unique attributes or a collection of the less unique attributes in order to identify the individual. But I'm just going to pull up here. I also, as a worker, can have a series of lists in front of me, those with a scheduled visit, those with an overdue vaccine dose, those that have been completed. There's a number of ways to kind of display this information. I'm just going to open up one of the individuals quickly and get a sense of what is included in the vaccine registry. So this person has been registered previously. I'm going to come in here and say that she's arrived today to receive a dose. And then I'm going to start to take a look at the types of information that are being requested. I know this is a little bit hard to see on your smaller screen, but there's certain conditions that apply. So for example, if the patient is pregnant or lactating, then you'll see that additional questions may pop up, the gestational age, for example. Or if there is an underlying condition, we could give a list of possible related conditions that they may be worried about with the vaccine, including chronic lung disease, diabetes, cardiovascular disease, etc. So if I start to include this information, then it's going to give me this as a part of the health record, that there's a risk factor for chronic lung disease, for example. And then I'm going to capture the information about whether or not they've been infected previously, as well as the dose that they're receiving, what the manufacturer is, what the given name is, what the batch lot number are, expiry date, etc. So all of this information is tied to this individual. The information is used also then to generate a notification, or can be, to send a text message to the person, letting them know when to return for their second dose. The system is also keeping track of those that have received a first dose, and it's scheduling an appointment for the next. asking if I want to complete, do I want to schedule the next date here for them to return and receive their second dose? So all of this right now has been working on the level of tools that are useful to the vaccine provider and tools that are useful for the patient in terms of notifying them of their visit. But in the background, all of this data is structured data that's being collected, and we have a dashboard set up to aggregate this data and make it be available for an analytics. So giving you, again, a sense of where the doses are being given. You can drill down into any one of these sites, giving you the total numbers of those that have had a first dose, those that have completed their doses, a breakdown between age groups. Any number of indicators are possible to establish. We've set up a series of them based on the guidance that we've been able to get from global organizations. But again, these can be adapted based on what the country's needs are in terms of being able to make use of this individual level data. For most countries, they would maybe have a mixed kind of system where perhaps in some parts of the country, they're able to do this kind of registry level data. They have mobile devices or they have a laptop persistent connectivity. They're able to do, point of care data entry, but just in parts. There may be other parts of the country where it's much more feasible for them to be reporting on paper, have that aggregated at a higher level. At which point you would be able to create also dashboards that mix and match some of this data so that you're doing a bit of a comparison between the individual level data sites and the aggregate sites. You can have both of these dashboards available to the right user depending on what their access levels are. But if we took a look, for example, at this patient previously that I was entering information on, if I had noticed that she started to have an adverse reaction. This is one of the key pieces of information globally that people, of course, are trying to collect about the COVID vaccine to see if there are adverse events and to try to be able to, make a quick decision about suspending use or determining if there are certain age groups or populations that are more likely. Then we have an adverse events following immunization module. This module was created actually over a year ago working with the World Health Organization and Gavi, and was just updated to include the adverse events related to COVID vaccine. And so if I'll just grab a random patient here and we'll take a look. Again, this is all dummy data, so nothing to worry about here. Some of you, if you've worked with adverse events following immunization before, you may recognize this form. This is actually based on there's one paper form that the WHO recommends to all countries collecting adverse events data, where you begin a notification process where there's going to be follow-up and an investigation done to determine if there are significant problems with a given vaccine. And so it's capturing the information about, again, the brand, the lot number, vaccination, the date and time. It's also collecting the information about what exactly were the conditions or the adverse events that manifested. And it has a couple of different levels in the program. I won't spend a lot of time on it, but these are meant to match the process in the country in terms of completing the investigation, determining whether there was an actual adverse event, assigning it a classification. And so all of this, again, is tied to a specific workflow for the country. It can be adapted, in fact, should be reviewed given the country's actual processes. And again, the data in the background can be used to trigger a number of actions. So when an investigation form is initially completed, it can be configured to send a notification to the investigator. So if somebody at a lower level facility is the first to identify a potential adverse event, it can trigger a notification within DHIS2 going directly to their inbox, for example, or it can be sending an SMS notification. You could do a direct link to the system that the adverse events people are using. So there's a number of ways that this data is meant to support not just the data collection, but also the process of completing out the adverse event. And again, if we go back to our dashboards, the data is being displayed and aggregated, giving a better sense of a kind of national picture or a district level picture about what is going on with a given vaccine. So you can see charts, for example, that we can scroll over here looking at the AstraZeneca seizures category. Again, this is completely dummy data, so we're not suggesting that you would have a lot of seizures from the AstraZeneca, but giving you a breakdown here of the different types of categories for a severe local reaction or for a fever. breaking it down for the other vaccines that may be at use in the country. This is Moderna, this would be the Novavax, breaking down by the total number of cases. Again, any number of analytics that the national program would like to have relating to the adverse events. I'm going to dive back into a couple of slides to show you a few more aspects of this. So one of the key things that we wanted to be able to do, there is a global repository for adverse events following immunization, which is called VIGIBASE. VIGIBASE is supported by the World Health Organization. It's run out of the Uppsala Monitoring Center in Sweden. And so we've worked with them for the last 3 or 4 months to ensure that the adverse event reporting that is taking place in DHIS2 can be connected and reported to this global repository. Again, giving more of a global overview of the specific adverse events that are taking place across countries following trend lines within a given vaccine or population. And so we've adopted the E2B individual case safety reporting standard for this purpose. We've worked right now with the country of Mozambique to be one of the first implementers linking DHIS2 to the VIGIBASE system. But we also know there are some 30 or 40 countries that already are meant to be reporting to VIGIBASE that also use DHIS2. And every one of them is a candidate to be using this system and being able to report not just their COVID vaccine adverse events, but also all of the other vaccines that are a part of the adverse event following immunization program. Another thing that I wanted to show is that the immunization registry can be linked to printing out a vaccine certificate. So we don't have a specific vaccine certificate inside of DHIS2, but many countries have made use of the data coming out of DHIS2 to generate their own vaccine certificate. You may know that there's a lot of conversation right now coming from WHO and others about what exactly belongs in these vaccine certificates and how should they be used. There was some draft guidance published just 3 or 4 weeks back that we've taken a look at. We've also been working with a group out of India called DIBOC that has an open source approach for generating certificates. But meanwhile, a number of countries haven't been waiting for that guidance. So I'm showing you an example here from Rwanda, where they were able to generate their own vaccine certificate using the information that the national program wanted to include, generating a QR code. You can see a picture here coming out of the local news agency of a woman that is received her vaccine and is showing her digital certificate on her mobile phone. So, and this can also be, again, linked to notifications. So once the patient has, or the client has received their second dose of the COVID vaccine, they can receive an SMS notification letting them know where to get their digital certificate, where they can log in and receive that information. So the system itself is open. It's available for a very simple vaccine certification application to be put on top. We've seen many countries doing this. Sri Lanka recently worked with the same group that we've been working with, DIVOC, to set theirs up. Previously, Guinea-Bissau, Uganda, other countries had already been generating travel certificates or test resulting certificates. So it's something that I think there's a lot of different examples about how to set this up and what kinds of information to include. And we will continue with our work with the WHO and with the DIBOC groups to ensure that whatever the kind of standard recommendation is conforms to the global guidance. I was going to step a little bit away from the specifics of the functionality to talk about kind of capacity and performance of the individual level data in DHIS2. So in December of this year, Bangladesh entered into a massive MMR campaign where they were going to immunize almost 40 million children. And so we recognize that as an opportunity to work closely with them and ensure that our DHIS2 platform would be able to handle that level of use for the COVID vaccine approach. So we worked very closely with UNICEF that was responsible for that campaign in Bangladesh and learned a lot from that campaign. We spent, before the campaign started, we made maybe a dozen different improvements to DHIS2 in order to be able to handle the volume that they were going to experience. And then everything actually worked really smoothly. They had over 50,000 users. They did register 36.5 million children at 40,000 different sites. So giving us a good true world baseline to say that, you know, it's possible to reach this kind of scale in as well for COVID vaccine. So we took those improvements that we made to the DHIS2 platform, and we actually backported them as far as we could into various versions of the software for the countries that are using DHIS2 already and that would need to upgrade a bit in order to be able to handle this kind of volume. So just giving you a sense right now of the scale that some of these implementations are at. Sri Lanka right now has 16 million individuals with enrollments in the system for COVID. They're using a couple of releases old DHIS2 234.4. Bangladesh is using even a slightly older version of DHIS2, and they have 38 million tracked entities in there with 200 million different events. So we're feeling fairly confident that as a platform that DHIS2 can be scaled to this level and can support these very large-scale immunization efforts. We do have recommendations about how best to set it up and what kind of problems to avoid when you're setting up such a large-scale solution. And maybe before I dive into interoperability, I'll look at that just for the flow purposes. So Rebecca had mentioned how we consider these COVID programs to be kind of a package. They come with documentation, they come with the metadata that you would use, and they're based on the best guidance that we've been able to get from global partners. However, every country typically needs to review all of that metadata, compare it to their own national strategies and guidelines, and possibly make adaptations to the program in order to ensure that they're collecting the data they want and it supports the work processes that they do. Meaning that there must be some kind of adaptation process that you would get the right stakeholders in the room to adapt the system and ensure that it is meeting the needs of the local environment. Very important to consider whether the data that you would collect, for example, in the vaccine registry, is that also going to feed into your HMIS? If so, are they using DHIS2? How would you set up your routines to exchange data between the individual level system and these aggregate HMIS systems? And many countries also choose to do either their own applications on top, such as the vaccine certificate, or other changes to the software. And for us, every time that happens, it's kind of a learning opportunity. You might uncover new bottlenecks, areas where, for example, you're asking for more data in a single call to the server than we had expected. And so you may need to do some optimization, really want to make sure that you're doing some field testing with large amounts of data that would match the kind of expected growth in the country. For example, this week we've been working with Nigeria, who started to collect a photo image for every one of the COVID vaccines. We did not exactly design the tracker to be able to handle the 50 million individual pictures that they would be collecting in Nigeria. So we've been working with them to try to optimize having perhaps a lower quality image, helping to expand their server space to accept these kinds of things. There's a lot more that we could share here. We have a number of different webinars that are published online that you can take a look at to see more of this kind of information. I would say that kind of key to this is to pick a version of DHIS2 that we have optimized for this very large scale kind of implementation. So going forward, we have actually a new release of DHIS2 that just came out yesterday, 236. All versions of DHIS2 going forward have the fixes that we have been able to create, but we were only able to backport them to several previous versions. And so really recommending that the country upgrade to 234, 235, or 236 if they're going to run this very large scale system that is relying on either the aggregate or the individual level data. There's a lot going on with the amount of data that comes in and how much the dashboards might be used, at what level in the country they might be used. And so you're going to have much better performance if you choose to run DHIS2 on one of these more recent versions. So maybe the last thing I will say, because these are often questions to us, maybe I can get ahead of some of those questions, is about the interoperability of DHIS2. DHIS2 is an open source platform. We have always designed and intended for DHIS2 to be connected to other systems. We run all of the aggregate side of DHIS2 using the ADX standard to be able to connect to any other aggregate kind of system. We created over the last couple of years a FHIR interoperability layer that allows for the exchange of patient level data, clinical level data with other systems that are also HL7 FHIR compliant. But I would say that from this perspective of FHIR, there is definitely a need for adaptation, always. The system that you may be mapping to probably is using different versions of the FHIR standard, or maybe classifying a patient visit differently than the DHIS2 system does, or any number of things that they have chosen to do differently. And of course, many systems don't use the FHIR standard at all. Many of the systems in countries are either locally made, or they're privately licensed, or they weren't designed to exchange data. So there's really a lot of effort that needs to go into this kind of an integration of mapping between the systems. We continue always to be working on specific integrations with systems where we think it will have a major impact. I've already mentioned the VigiBase connection that we've worked on, and the DIVOC for the vaccine credentials. We also are reviewing right now the recent release of the WHO Digital Adaptation Kit. They've put that out specifically for antenatal care at the moment, and we have a draft of the HIV case surveillance. But a lot of what is included in there are the same kinds of standards you would apply to any kind of facility level or clinical level data. And so we're constantly working with these to make sure that we're adhering to kind of the best global recommendations and making it as easy as possible for a country to interoperate. We also have been and are linked to many other of the global good software that's out there that countries are using. All of those listed here, ODK, ComCare, OpenMRS, all of these have been integrated with DHIS2 many times previously, and it's demonstrated that it's always possible to do again. But I do have this message here on the right just to say there's no such thing as plug and play when it comes to interoperability. It's a complex approach to try to link two systems together, especially when those systems may both be changing over time as new requirements come in. And so you really want to plan ahead of time for your implementation, the amount of time and effort and resources that go into ensuring interoperability. So with that, I know we've touched on quite a lot of topics. We have the slide deck that I'm showing now has much more information in it. We'll definitely make that slide deck available to you with a lot of the screenshots from the demos that we shared and some more in-depth information on some of these pieces. But maybe at this point, we'll try to save the rest of the time here for some of the questions. So yes, I'm seeing there are at least a couple of questions that popped up in the Q&A. Blake, do you want me to just tackle some of those to begin with?
Yeah, that's a great place to start. Thanks, Mark.
Okay. So there's a question. Let me switch back over to
I can read them out for you if that's easier.
No, it's fine. I think I've got it pulled up. I just wanted to switch back to the tracker screen here. There was a question about how appointments are managed and whether this can come from another health system where the health worker needs to schedule the appointment. So within the system, you would have a person, a tracked entity. In this case, the person is named Toto. And we're going in here. You're always able to, in the system, schedule a new appointment at another clinic, except for this one, which somebody else created, and I'm not the user that has access to. But you can either schedule an event right here at another site that is a DHIS2 user, or you can make a referral directly to another site as well. And those would carry over so that the user at the other system or in my clinic, they would be able to view that there's a scheduled appointment. Back on that opening page here, I can have my working list, for example, of those that have a scheduled visit. So right now it's just these two that had a scheduled visit for today. So this is the way that DHIS2 managed them. As far as being able to exchange that with another system, again, that's an interoperability question. It depends very much on what the system is and how they accept flagging what an appointment is and what format they want to see that in. I would say that it may be more effort than it's worth if you want to really directly connect two of these systems just for the purpose of scheduling. If there are already existing approaches to being able to ensure that the other site has access to scheduling and being able to send the patient with a record or something, that's always something possible, or else expanding the user base of DHIS2 so that they can schedule directly in the system. But there's not, I think, a simple way to ensure that that scheduling happens. You can send a notification. You can make the people at the other side that aren't using DHIS2 at least be recipients of SMS messages, so it could trigger a notification when an appointment has been scheduled, for example. So there are a number of ways to try to do it. And then the question about, is the tracker accessible via the mobile app? Yes. So that's one of the things about DHIS2. Everything is available through the web or through the mobile device. So here's a screenshot of just what it looks like within the Android application. This is the native DHIS2 application. So you configure your program once, and it's available either through the web or through Android. There's some, of course, slight differences in how it displays data and how it handles some of the functionality based on the screen size and based on what the Android kind of underlying toolkit can handle. But yes, and in fact, Android is the solution to be using in an environment where you have kind of less reliable connectivity. So the web browser is meant for those areas where you have a persistent connection, because every piece of data that you're entering is being sent directly to the server and stored there so that it can never be lost. But with Android, you're having a local copy that is stored to the device. And then you can sync that copy whenever you have the opportunity to connect back to the network. And so for many countries and many parts of many countries, Android really is the only solution that they can rely on if they're trying to do digital data entry at kind of the lowest levels. So those are the two questions I've seen come up. Are there additional questions that people want to add to the Q&A, or does, I'm not sure if people can speak up at this point, Blake?
Yeah, if you want to ask a question direct, I think you can request to do so, or do drop it in the Q&A. While that's happening, Mike, I have a question. You mentioned neatly about working the vaccine delivery toolkit into current configurations. Mm-hmm. Given the size of a lot of the data implementations, like the slide's perfect, 16 million extra records and then enrollments and then extra events with it. Did you have any problems with the scale of data also coming into the systems and not just the kind of configuration?
Yes, for sure. So for example, Android, which we were just looking at, things can get really kind of intense when you have thousands of offline workers that are then trying to sync a bunch of events which they have stored over the last week. Right. So we've had to work actually over the last year to really optimize kind of the Android calls as much as possible so that they don't clog up the server all at one time. Android also, just as a software platform itself, constantly is repeating those calls until they are filled, which again can be really problematic. If you have 100 records that did connect but one that didn't, that one might crash your entire server because it just keeps pinging at it. Right. So there are a lot of these kinds of considerations that we've really had to work on to try to optimize. Again, we've been able to make it work really well in these large scale data environments, but it's definitely something to be aware of and want to be testing before you try to go live on a large scale. Mm-hmm. Rebecca, did you want to add something to that? I just saw your face appear again.
No, it was just to, hello. No, I think
just to join us.
Really
okay.
Quite well.
Sure. It also made me think, Blake, you were talking about those countries that maybe have an existing DHIS2 implementation, and maybe now they want to add one of these packages. So that comes with its own set of considerations. So often the HMIS or the existing tracker that they have in a country is running on an older version. Mm-hmm. So you might want to decide either to upgrade the existing version or else have a new instance that is just for the COVID vaccine work where you're running a more recent version. We also have often seen and even recommended countries that they actually do keep their individual data separate from their aggregate HMIS, partially for kind of privacy and security reasons, that you may want to have stricter access to the server that houses the individual level data, but also partially because you might require more resources for the individual level data system in terms of the hardware configuration. Mm-hmm. And so, again, these are the kinds of things that you really want somebody that knows how to configure a server and knows how to manage it, making these kinds of decisions. You will very often see countries setting up some kind of automated exchange between maybe their COVID surveillance system and their HMIS. So the data are stored separately and they're not transferring all data to the HMIS, but they aggregate that data first and then they just transfer the aggregated data to the HMIS. So again, there's a lot of kind of considerations there about what's going to be the optimal way to make sure the data ends up where it needs to be.
That's great. Thank you so much. I see we've just hit on the hour, which I think at this point means we are kind of at time. and with no extra questions, I might say if there's any additional follow-up that people have for either Mike or Rebecca, reach out to them on Hopin, or I think their email addresses are associated via the agenda. I'm sure they would love to hear from you. And
Sure.
Thank you so much also for Mike and Rebecca bringing your considerable expertise to this session. And thank you everyone for joining. There is going to be a break at this point for 15 minutes until about 4:15 p.m. CET time. And then following that, back at the main stage will be the closing sessions, a fireside chat on the paradox of the grand bargain and the global pandemic, which is going to be looking at technological developments, about donor funding, and then where they're thriving or maybe falling short in the current environment. And a final note, just to say, after the summit is over, a survey is going to be sent out, and we'd really appreciate it if you take time to share some of your experiences through the summit on that. But for now, thank you once again, Mike and Rebecca.